talk about testing options, we all know the Dix-Hallpike. There are some updates to the ways that we can test for patients who maybe don't move as well or aren't getting a good response. So the loaded Dix-Hallpike is the new, more recommended version of the Dix-Hallpike. All it is this chin tuck at the beginning towards the side you want to test. You hold it there for 30 seconds before you go back into the Dix-Hallpike. On all of these videos, I have an X on my shoulder so that you understand what side I'm testing, what side I'm treating. It's always going to be the left side, just so it's consistent throughout the content. But what we're seeing is that this is going to give you a greater dizziness response and a greater nystagmus response so that you can better evaluate. If you have a patient you know has BPPV, don't do a loaded Dix-Hallpike. It's just going to make the test more provoking to them. So this might be someone who I got a negative on a traditional Dix-Hallpike, and I really feel like it's BPPV. So I'm just going to add this chin down for 30 seconds and then take them back and see if I can get a more robust response, a more accurate test actually than the Dix-Hallpike. The Dix-Hallpike has about a 17 to 18% false negative, and the loaded Dix-Hallpike only has a 4%. So it's actually more accurate of a test. We can also adjust head over the pillow. We don't need to be taking these patients over the edge of a bed, especially our elderly patients. This is just as it's equivalent to the Dix-Hallpike, has the same sensitivity and specificity, and it's much more comfortable for the patient. So just keep that in mind. We don't need to be taking these patients over the edge of a table. Sideline test is obviously much more simple. People are always sitting on the edge of the mat table, so it's really easy to just have them lay to the side. It's just, again, as accurate as a traditional Dix-Hallpike. It's more comfortable, especially in the elderly population, to get them in this position. Also more comfortable for patients with obesity. It's really hard for all of that tissue for when they go back, and all of that pressure is on their chest. So my obese patients, I'm typically going to also do this sideline test on. The reason I want to bring up this kind of sideline position is when we talk about a lot of the different CRMs and repositioning maneuvers, it can be overwhelming because you're like affected side, not affected side, right, left, which way do I start? And you're always like getting very confused. What you're going to see is that for posterior canal, all of these maneuvers that we talk about start on the same side. They're all going to be either in this sideline test where you're in the position that I'm in here in the video, or it's still in this sideline, but your head is straight. So as you go through these videos that I have for us on the different types of repositioning maneuvers, they're really all doing the same thing. There's just very small changes about them. And so if you can think, okay, if I'm testing my left in this modified sideline, right, that's my affected ear, just start these maneuvers in a modified sideline for that side, and you'll probably be correct. And you'll see that trend through these videos. They're all going to start like this for left posterior canal. That will hopefully reduce some of the, which way do I go? Okay. Another thing that is coming out more recently is instead of actually doing a Dix-Hallpike, we may be able to still get a good assessment of both posterior canals at the same time with this head hang test. And so just taking someone straight down into neutral in the middle can provoke a torsion right or left, and then we know which ear is affected based on the torsion. This is something you would have to do in goggles because it's very torsional specific for us to know which side is affected, but it keeps you from having to do a left Dix-Hallpike, a right Dix-Hallpike. You may be able to actually get a true test with just doing this central head hang. I have not moved 100% to this yet, because if your head hang is negative, then the next step is to go ahead and do the Dix-Hallpike. So you always are looking at your patient and being like, how well do they move? How much extension do I get in their neck? You're weighing the pros and cons of like, if I get them up and down one time, like that may take 20 minutes because they don't move well, or I have a 25-year-old that can move like crazy. So I can be more thorough and go through all the motions. You're really doing this based on your patient, but just wanted you to know what your options are. So what this is doing is taking you through actually what I would recommend, this 1, 2, 3, 4, as if a patient moves well, kind of my actual testing sequence, because this was on the Slack group this week or last week. It came up If I think it's right posterior canal, I'm going to take them right down into right posterior canal. And that's not always true, because then you don't know what anything else looks like. And so if I think something is right posterior canal and I have a patient that moves pretty well, I'm actually going to try and do my right Dix Hall Pike last, because then I already know horizontal canal is good. I know left posterior canal is good. So when I go into that right Dix Hall Pike, I get a positive response. So I can just roll right into treatment. I don't have to second guess myself like, ooh, right's positive. I wonder what the left looks like. What's horizontal canal look like? So you're actually trying to get the correct canal last, not first, in patients that move pretty well. And so this is just a depiction of doing the supine roll test first for horizontal canal. And then you can come back up, go into this head hang to see if you can get posterior canal. And if that's negative, you can then do the Dix Hall Pike. And we're going to talk about the deep head hang and the role that that plays in some of these variants. And so I've actually started doing a deep head hang first before my Dix Hall Pikes in patients who move well, because it has the benefit of taking a non-ampullary arm posterior canal BPPV and converting it into one that we can treat. And I know that doesn't make sense right now, but in 20 minutes it will. So just kind of keep that in mind. There is a purpose also for doing a deep head hang before the right and left Dix Hall Pikes for some of these variants that we're finding may be more common than we think. Let's go into treatment. Okay, so those are kind of like the basics of testing, different modifications you can use, but now let's figure out like how do we treat these challenging patients. So modified epley, if you guys see that, that is basically the traditional epley has vibration added in the positions. So modified epley is without vibration, but it's still like the canalithiasis repositioning maneuver we're all familiar with. So you can add it or not add vibration. It's not wrong to try it. I'll try anything if I think this person has BPPV and it's not clearing up. So you can do the modified epley with a pillow under the shoulders if that's more comfortable. And we're actually going to talk about the Gaines maneuver, which you can do that with as well. So the Semont versus Semont Plus, I'll show you a video of the Gaines maneuver, the Lee maneuver, and there's actually a sleeping position that you can give a patient after you reposition them, that they can self-treat again during their sleep that night to improve the success of our maneuvers. It's not a restriction, but it's actually a self-treatment they do before they fall asleep. So let's dive into these. So the Semont or the liberatory are the same thing. You might see it, hear it both ways. But again, it's this first position here where you're in this modified sideline test. The Semont Plus is only different in that initial position of modified sideline. Let me see if I can get a pointer for you guys. So this, no, that's not right. There we go. So this initial position, so this is for a right posterior canal. They're in the right sideline, just like we would test them for right posterior canal. So that's your initial position. You sit, come down to a sideline test. The only difference between the Semont versus the Semont Plus is the Semont Plus right here in this position, their head is going to go down 150 degrees. So it's an extra 60 degrees from this 90, okay? So the Semont is just quickly over face down. And the Semont Plus is this starting position in modified sideline. You're actually taking them off the table. And then the rest of the maneuver is the same. So I have a video of this because it definitely, I feel like me, visual is way better. So I'm going to start with the Semont. So here I'm just that modified sideline test that we all know for left posterior canal. You're going to wait your 2 minutes. I don't wait in these videos, so save you the hassle of looking at me for forever. Quickly, that patient's going to go face down. If they can move themselves, I try and have them move themselves. They're going to move faster than I can move them, and speed does matter on this. I have them put their hands in front of their face so that they can decelerate themselves as they try and stop the mat from hitting their face. Okay, so that's the Semont. Now here's the variation. When you do the Semont Plus, the goal is to get their head down deeper. And that's for what I think for reasons you'll see in this variant type that we're going to talk about. But if you see I have a pillow here, you can use a chair in the clinic or a stool. It's best if you can give them a surface to put their hand on to support themselves, because you can see here, I'm going to go way down And this makes them feel like they're in control and they're not falling off the table. So I'm at this 160 degrees. You're dropping them 60 degrees or 150 degrees. You're dropping them 60 degrees lower than what they're used to for the Samant. And then the rest of the procedure is the same. After 2 minutes, quickly go face down and they stop themselves with their hands. And then they wait there another 2 minutes and then they sit up. Again, these are patients that move well. I'm not doing a Samant on someone who's like 75 years old unless I absolutely have to for some reason. So that's your Samant. Okay, the Gaines maneuver is here. Again, same modified sideline position. This is for left posterior canal. So it's the same thing we just started with for the Samant, but instead it's going to look a lot more like the Epley. And it's basically almost exactly like the Epley. So after this position, what would we do? If they're in a left Dix Hallpike here, we would just turn them into a right sideline, right? And that's what we're going to do here. So now we're going to go right. And then in right sideline, what you add is a head shake. So they're just going to shake their head to try and knock those canalets off. And then they wait again for another minute, and then you sit them up. Okay, so what I like about this one is that some patients are like, well, if I get people in a modified sideline test and it's positive and I want to treat it, like, what do I do? Because we're so used to like, okay, they're in a Dix Hallpike and now I'm going to go to the Epley because I'm going to roll right into treatment. Well, the Gaines is basically that same version, but from the modified sideline test. It just adds that head shake in sideline. Okay. This is the depiction of the Gaines from the research article, and it's really hard to follow from the depiction. So I tried to write out the directions a little bit in better detail. Okay, so then the Lee maneuver is one of my favorites that I've started doing. And this actually came up on the Slack group. Like, I have a patient who I think has BPPV, but has no cervical extension. How do I treat them effectively without moving their head? And so I actually used this one 2 weeks ago because I had a cervical central stenosis, no rotation, no head cervical extension that I felt comfortable with, like full paralysis. She was waiting for surgery. It was not a good situation, but she had terrible BPPV. And so we did this one session and it worked phenomenal on her. So again, this is like the left sideline, only you don't have your head rotated. So you're just in true neutral sideline instead of that modified sideline test that we've been talking about. So the only change is your head stays in neutral. This is again for left posterior canal. So you're going towards the affected side like all the other ones. You wait there for a minute or two. And then I am going to move them straight into right sideline. So it's like the Samant, only there's no head turn. It's just straight left sideline to right sideline. You wait here 2 minutes and 1 to 2 minutes, and then you sit up. Remember, on a lot of these, the speed is what gets the momentum of those otoconia moving, but we have to allow them time to move. So don't rush through these wait stages for these quick maneuvers. To do this particular one quickly, what I would do with that patient, I did not want their neck to move at all. I basically took her neck here, and then I had her grab onto my arms, and we just moved together as a unit. She held me and I moved her entire body with us, and it worked out really well. Okay, so this is the Lee maneuver. Definitely my go-to with anybody with cervical issues. And then the sleep maneuver. So this is supposed to be used in conjunction with our CRMs. So if we go through a treatment and at the end, sometimes we run out of time. We did 2, and that last one, we still got really bad nystagmus. And I'm always like, oh, I don't know if I got it. I really wish I could do it again, but we don't have time, right? The next patient's coming in. I'll give them this sleep maneuver so that they can self-treat again when they go to sleep. And all they're doing is laying straight back, and then they roll towards the side away from the side that we're trying to treat. So patient lays back with or without pillows, wait for 3 minutes, and then roll towards the unaffected or away from the side that we treated. And then they stay there for 30 minutes. What I just tell my patients is if I just was doing a left, like the rest of these videos, lay straight back in bed, roll to your right side, and just try and sleep on your right side. Whatever happens after you fall asleep, it doesn't matter. If you get out of bed, you get out of bed. But when you get back into bed, go back, wait 3 minutes, roll to your right side, and then just try and sleep on your right side.